both organizations as a result of COVID. So, and I think most of our beneficiaries have seen the things that have gone on. We have changed the way we do pharmacy services. For example, we don't have the everything is curbside now. We've moved our main pharmacy services over to Mendoza from the hospital. We have done we've shut down 2 of our community-based medical homes at Rio Bravo and Desert Sage temporarily. We've repurposed those folks to work in other parts of the facility. As we have de-scoped some services, physical therapy, occupational therapy, other areas, we've moved those folks to different parts of the hospital to help reinforce them. So that's part of what we're doing now. We've reorganized internally to the hospital to make a COVID ward and a non-COVID ward, and a COVID ICU and a non-COVID ICU. Partnering with the VA, we have a contingency expansion plan to move into their facility if we needed additional critical care beds, to convert their operating space into critical care space for patients. So a lot of things that we've been doing collaboratively. Elective surgeries are on hold right now. We've restricted the number of visitors that can come into the hospital. Like all facilities, we're checking temperatures and making sure that people are not febrile when they're coming into our facilities. So these are some of the things that we've done. I think this crisis has shown some challenges. That there are different policies for the VA and the DoD. For example,
Mike,
go ahead, Mike.
If I can, let me cover the same things you just talked about from my perspective. Then we can get into that other topic we spoke about.
Sure.
Is that okay? All right.
Yep.
So very similar. You're going to hear a lot of very similar things because Colonel Oshiki's team and mine have been coordinating a lot of our movements. We want to make sure we're doing things in lockstep so that it doesn't look like the 2 biggest partners in federal healthcare in town are not talking to each other, and we are. We talk on a regular basis. So from the VA perspective, we've done the same thing. We have had our clinicians go through all of their appointments, specifically in primary care, but across the board, primary care mental health. They've gone through all their appointments, and they've determined what appointments are appropriate for virtual care either being a Skype type or a Zoom type of appointment with your provider, or a telephone appointment. My last primary care visit with my provider was on the telephone. And a lot of the same things, fortunately, knock on wood, I'm pretty healthy. There's not a lot of attention that I need. So this is the right type of care to provide for a lot of our beneficiaries. And I know within the VA, and I think Mike's team has done the same thing. Within the VA, we've increased our video virtual care about 300%, and we've increased our telephone appointment care by about 1,000%. And so what this did, and what we were telling the teams, was that this is some of that tsunami on the other end of COVID that we're not going to have to try to figure out how to schedule appointments for. So they went through and scrubbed them. And again, we had some resistance on our provider side, but it's also care that the veteran has to accept. And that has been part of the other challenge. So, one thing that organizations like USA and your members could help us out with is encouraging people to accept those appointments, because it is the civilian market is doing it now. And this is becoming the standard of care for a lot of primary care services. Now, this is a clinical decision. Mike Amaral ain't making that decision. The clinicians are looking, and if that patient is appropriate, then they offer it. The other side of that coin, though, is that if they're not appropriate for virtual care or to be, pushed further out, we're still seeing them. We're still seeing a small subset of our appointments face-to-face if it's clinically appropriate for that to be seen. We too have moved part of our pharmacy operation out to the parking lot. There's a couple of things that I've challenged my team to do. We have a lot of traffic that comes into my building just to drop off a piece of paper, and that doesn't make sense to me. I'd rather look at something like the post office has, where you drive up and you drop your letter into that little snorkel thing, or whatever the heck you call it, that comes out of the mailbox that you don't even have to get out of your car. As Mike is well aware, parking is one of our biggest challenges on this campus. So if I can prevent a subset of our population from having to find parking just to come in and drop off a piece of paper, that's what we're going to do. And we've done that for COVID. So if you have care in the community documentation that you need to drop off, there's a drop box for that. If you have a care in the community prescription to drop off, you drop that off. Had a personal experience with that last week because I had to get some oral surgery done. Dropped off my prescriptions in the box. Didn't tell anybody. And I am really hoping that just because they saw the name Amaral, that it didn't get treated any differently. And I don't think it did. But within 24 hours, I got a phone call from one of our pharmacists saying, we received your prescriptions, did all the proper validation that it's really me. And then they asked me, is tomorrow okay for you to come in and pick up that prescription? The reason was, and this is going to be a good caveat to part of the next discussion, is that if I had enough time, then the preferred method to fill that prescription would have been through the mail order pharmacy that the VA offers. But we have veterans who come in just to get periodic injections, or our Coumadin clinic. All these things we've put out into vans. You might have noticed we have the mobile vet center sitting out in our parking lot for the last couple of months. That's because that's where we're doing these injections. It's a safe environment to provide that type of care. So, nothing that either of us are doing is compromising patient safety. So, you'll see that, and some of it's not going to be able to sustain. We don't need to keep people out in the parking lot to be giving injections. But some of these other capabilities, it stinks that neither of us, and I take the blame for the piece down at William Beaumont, that neither of us have a true drive-up pharmacy capability. I screwed that up in the design for the new hospital. There, Oshiki, I took a bullet for you.
Thanks, brother.
No, that part of that just goes to these national templates that we're forced to use. But it really is a shame because that's the model that we're doing. So as we're trying to figure out some spit and duct tape to have a type of drive-up pharmacy capability. So with that, I think I covered the same things you did, Mike. I'll tell you that the concept that they came up with and that our teams worked on, that if they had to expand their ICU, that they would move non-COVID ICU patients into our ambulatory surgery unit, that we did some fixes to make sure that it could truly serve as an ICU. We even
and they've actually tested it. They put patients in there. We took care of some folks in there just as a as a practice. Make sure the oxygen systems works, the monitors work, and we validated it, so it's ready.
Yeah, and all of us should be real proud. I always was when I was on the other side, but now with the relationship that we have with William Beaumont and that partnership, I'll tell you, we here in El Paso should be incredibly proud and bragging about what we have here with that relationship. So, Mike, I don't know if you had anything else on those specific topics, but I didn't know if anybody had any questions on that portion of the discussion.
Yeah, open to any questions before we start talking about some of the gaps.
Mike, this is JP Hogan up in Dallas, Mike Amaral. As you run through these new processes at the VA, like virtual appointments, long term, as we get past this, do you see this as a new model of care for veterans? We do more in a virtual basis?
Absolutely. That is my goal. I want to at least sustain what we've been doing, because my question is, if it was appropriate care to give for that veteran for that appointment, why wouldn't that review and that transition or reaccommodating of that appointment be appropriate for other appointments down the road? You know, a lot of people's concern, you know, there's a rumor out there that if I'm not seen by the VA, you know, every 6 months, every year, whatever the magic number is, that I'm going to lose my benefit. And that's just absolutely not true. And now there is a consequence that if you're not seen by your primary care team every 2 years, then we will pull you out of that team, kind of put you in a holding pattern, but it's not where you lose your benefit. However, if you get seen by these capabilities, by these modalities, then it counts as being seen by your team for that 2-year mark. So it's not appropriate for everybody. You know, if you have some type of underlying chronic health condition, it is probably not appropriate for you. Mike Amaral is not a clinician, but you know, for a lot of us, for a lot of our younger veterans that come in and you know that they really don't need to be seen face to face, it absolutely is a capability that I want to sustain. Additionally, people who live way out in Jeff Davis County, for example, what % of our care could we provide them virtually and prevent them from having to come all the way to El Paso to get that care? So simple answer is yes, absolutely. In fact, I want to expand it.
Mike, this is Anna Schwartz. Along the same lines, I'm excited for the opportunity that this is creating and accepting telemedicine much more. There's, I think, been a fear of adopting it. And I think it can really help barriers to access. But do you know if there are any studies being done or planned to be done to perhaps evaluate the outcomes of similar types of visits over time and to determine patient outcomes so that there can be some sort of, reporting a year later that will kind of be more evidence-based as to which visits are appropriate for telemedicine and which ones maybe are not, to give both providers and patients the comfort that they might need to utilize the service more? You're on mute.
I can talk a little bit about that, Emma, from our perspective, and it's probably true for Mike and his team as well. We're about 80-20 right now in terms of our primary care visits. There's obviously some things that you can't. It's very difficult to do a woman's health visit remotely. It's very difficult to do an orthopedic surgery consult virtually. So those things have got to be done in person. One of the things that we've done is we've segregated our acute ill care from our what we call our clean care, and we've done like, for example, women's health and the well child visits are being done in our SFMC clinic. We've converted that into what we call a clean clinic, so we're not seeing any acutely ill folks there, trying to reduce the chance of cross-contamination in that environment by putting all that care in one place. And then moving the folks that have acute respiratory. So if I have a cough, if I'm sick, we have one place that we have all of that acute care being done. That's non-emergent acute care for respiratory conditions, and then that's at East Bliss. And then at Mendoza we've got the combined primary care that's not the at-risk population. So the pediatrics, and the well women are and certain other things are being done at SFMC. Then Mendoza is sort of the all others. And Mike, you guys are kind of triaging some of what you're seeing, the virtually versus in person, right?
Yeah, that's correct. So for the scheduled appointments, we're going through the process I described. The clinical team is looking at the appropriateness of that care. They're offering the virtual care. If the veteran declines it, they look and see, is that care appropriate to be pushed further down the road once we return to some type of new normal. But if they're clinically, if the clinical team says, no, we need to see this person when they're scheduled, then they still see them. If somebody walks in, then we do a screening at the front door and we set up a small area that they'll do that nurse triage that occurs anytime we have a walk-in appointment. So bottom line answer is yes, Mike, we are. Anybody else have any other questions on that?
What you were?
Oh, sorry.
It does. I just think that this is probably the most monumental shift in how a lot of care is provided. We've never gotten to experiment like this countrywide and in so many different settings. And I just think it's a really good opportunity to do some retrospective reviews, maybe after a year, to kind of look at what were the changes and what settings that work the best for patient outcomes, for cost, from a cost perspective, from a lot of different things. I think that could be really interesting.
Yeah, that is a great point. And I'm going to check to see if the VA, because VA-wide, they've done about a 10-fold increase in the number of virtual care, the video care appointments. And so I'm going to ask if they're doing any study on the efficacy of those appointments. But you just stop and think of it from the consumer perspective. When I go in and see my provider, it's dialogue. Unless I have an acute issue that's going on, then it's not where they're doing a lot of these things. Yeah, they check my blood pressure and all that stuff up front, but a lot of it's discussing my labs. Well, you can still discuss the labs over the phone or virtually. So you think about normal preventive primary care, and unless you've got chronic conditions, as a consumer, I don't see where there's a need for that in the same room face-to-face visit. Now, Mike's a physician, so he's going to have a lot more knowledge on that. But again, Mike Amaral always shoots straight. One of my concerns is that if you accept a virtual care appointment, you're not going to get paid to drive into your appointment through the beneficiary travel program. There are some people, especially from way out in those far counties down in our eastern sector, that they're making some bank on their beneficiary travel. And when I went to a meeting down there, I had two of them who actually came right out and said, no, I'd rather come to my face-to-face appointment in El Paso, because then the VA pays for my trip to Costco. So, we are fighting that one now. If the VA, if we offer that type of care within the VA system because it's clinically appropriate and you decline that appointment, it should be a matter that you forego beneficiary travel. But that's kind of a different topic. So Mike, you were going to say something about the appropriateness of virtual care.
Yeah, I think the triaging is important, and there, like we were talking about, there are things you can do virtually, and we are finding that there are so many things that we can do through a telemedicine visit that we never really thought about before. And as we continue to expand the capabilities, we're operating right now on an exception from Health and Human Services that allows us to use virtual platforms like Zoom and FaceTime to do HIPAA issues. To talk about healthcare stuff that normally we wouldn't be allowed to talk about in a platform like that. I think we will find going forward that we'll have to have HIPAA compliant platforms that allow us to do these things. The DoD has done some of that already. I think the VA was doing a similar thing to try and get HIPAA compliant virtual health platforms, right, Mike? I heard something about. So the new primary care, the reality will be we'll have a lot more of the virtual platforms as part of what we do on a regular basis. I think the face-to-face encounters obviously are still important, but we're, like I said before, we're about 80% right now. We're doing virtually, and we're finding that we can do things that we never really thought about before. That you sort of took those face-to-face visits for granted, and now we're going, hey, you know what? You really can do a lot of this in a different venue.
Yeah, and kind of piggybacking on that a little bit, and then we'll move on to the next topic. The number of veterans who come in for an appointment because they need a prescription renewal. Again, not a clinician, but you have me draw my labs, and then we have a Zoom session to talk about, yeah, everything's good, we're good to go. We'll go ahead and put in the order, and you'll be receiving your medication in the mail in the next 7 to 10 days. It's a more efficient way to provide health care with no compromise to patient safety. So with that, and we've both talked about what we're doing with our pharmacy. And Chris Lidner, we see your question. We'll get to that at the end. But with the discussion about pharmacy, one thing that's happening is Mike is doing some shifting in how he's providing care during the pandemic, especially here in El Paso, where hopefully our numbers seem to be trending the right way. Knock on wood. But we have seen an increase in the number of DoD beneficiaries, the dual eligibles, us old retirees that are eligible for care in both systems. We've seen a migration of prescription coverage, of people coming to get their prescriptions filled through the VA versus over at Beaumont. Partly because they get the drive-in service down in Mendoza, which I think is fantastic. But I think a bigger part is the VA has a robust mail order pharmacy program. All of our prescriptions, I take that back. All of our refills of normal, routine, non-controlled substance drugs get mailed out to our veterans. A very small number, that don't have. We have veterans who don't have an address, and they're not on a postal route type of, really off the grid type of prepper type of folks. They've been doing great through this whole pandemic, by the way. But so a small subset that we can't fill through mail order pharmacy, but the vast majority we can. Another one is if I go and see my provider and my provider wants me on antibiotics, that's not something we want to wait 7 to 10 days to get started. And so that's something that you would pick up face-to-face, in the clinic. The challenge is the way that the DoD rules are written is that unless it's a generic, and Mike, please correct me if I'm wrong, unless it's a generic drug, you have to pay a copay to get mail order service for your pharmaceuticals.
Yeah, and that's really a challenge because this is one of those gaps between policy for the VA and the DoD. TRICARE actually disincentivizes the use of mail order pharmacy by having a copay. So we, if you show up to William Beaumont and pick your prescription up, you don't pay a copay. But if you use the mail order pharmacy, which actually, is better in terms of not having to show up and put yourself at risk and do all these things, then you actually have to pay a copay. So we are putting a financial incentive for folks to do the things that we don't want them to do. Mike and I were talking about this the last week, and we do similar things with urgent care versus ER. We actually for a long if you went to an urgent care center, which is a fraction of the cost of an ER visit, we made you pay for that. You had to pay a copay if you went to urgent care. But if you went to the ER, which is a whole lot more expensive, there was no copay for that. So what's somebody going to do? It's kind of like the travel thing. For the VA, we incentivize things that intentionally or not, that are the opposite of what we want folks to do. And we have to break that paradigm, I think, if we're going to get folks to do the things that make the most sense. The VA cracked the code on mail order and pharmacy, and that benefit is something that our dual eligibles have figured out. That's why they're flocking to the VA to do things that they used to do at William Beaumont. And I think if we can get those programs to have similar benefits on both sides, then we can incentivize the behaviors that we want.
Yeah, I personally think it's Oshiki just trying to balance his budget, but that's a separate conversation. Of course, I'm kidding on that, but
on the back of the VA, you bet, bro.
Hey, we've got notes on that, and we'll take a look at it and contact everyone and make sure we can get an idea of how we might fix that.
Hey, Lance, another piece of that, we were talking about this morning with my team. Another challenge that we have, and I'll just throw an example out there, Lyrica. Lyrica is on the DoD formulary for their pharmacy. It's not on my formulary. It would have to go up for a higher level review, which they're going to say, no, there are generics out there that do the same thing, and they can just get that generic. Now, normally we have the authority to substitute a generic version. If your prescription says Tylenol, we can substitute that with the generic version of acetaminophen or whichever one it is. We can substitute that. We can't just do that for other medications. And so it's a frustrator for our veterans that if a community provider who just chooses not to look at our formulary writes a prescription for Lyrica, it's going to take extra time and extra frustration with that veteran, because then we have to call the provider's office back and we have to say, that's not on our formulary, it was disapproved by our higher headquarters, what's an alternative, or that we'll suggest an alternative. But, it's going to be the same thing for our DoD beneficiaries who want to come over to us, which again, we have no issue with that. But there's going to be challenges because we're not operating on the same formulary. So, if you want to bring it up, it should be the combination of the mail order pharmacy benefit with zero copay for DoD beneficiaries, as well as, operating under a common formulary.
So you want a common formulary between DoD and VA. Mike Oshiki, does that work?
I think it does, and we've seen that we used to have what was the PEC, it was a committee that looked across DoD and VA and said, what are the things that we're all using? What are the top 10? How can we, I mean, there is phenomenal opportunity for collaboration that I think will, is a benefit to both services, because one of the challenges is folks end up cherry picking, like, okay, well, no, I can get this from DOD, I can get this from VA, and they go back and forth, and there are some gaps there that really would, that with a common formulary could be closed. And we're doing it in other areas. I mean, we have joint clinical practice guidelines where a clinician, whether you're working for the DOD or the VA, is gonna, for example, the diabetes, the DOD VA, the clinical practice guidelines, CPG, if you're on either side, you're gonna get the same care. You're gonna be approached the same way, whether you're being seen in on the VA side or on the TRICARE DOD side, and I think there is phenomenal opportunity to do that in the pharmacy realm as well. Would you agree, Mike?
Absolutely. In fact, I was talking with some of Mike's team a couple weeks ago, and apparently when they were going through the planning for a new DOD hospital, there was talk about a combined, specifically pharmacy and laboratory. I mean, how much sense would that make? But again, apparently the challenge was the variance in the formularies. And this is all directed up at the policy level, up at, big VA and big DOD. Is it something that would be real nice if we could control locally? Because I would love nothing more than to have, a main pharmacy that's jointly run with the same formulary, the same benefit over at Oshiki's place, and then maybe I put one the same way at my West Side clinic, just as an example.
Gentlemen, if I could interrupt you for just a second, Mike. I know we only have about 20 minutes left on this call, and I've seen several requests for information specifically related to the new Beaumont, and not the least of which is the most recent question on how the GAO study will impact the progress towards the Army medicine falling under DHA. And I think these are questions people would love to have your opinions on, if not fact. So if you could shift to that pretty quickly, we'd greatly appreciate it.
Sure, Richard. And one of the things that that COVID has done is it has really shown the value of military medicine to our nation, not just to the military, but you've seen military medical units deployed to New York and Seattle and other locations to reinforce the civilian healthcare infrastructure in those places. But all of those come at a cost. So the providers and nurses and medics from William Beaumont and Fort Bliss deployed up to Seattle and New York to reinforce those areas. I mean, and that meant they're not at William Beaumont, and in El Paso, so when we were looking at like the infection curve continues to be a challenge here in El Paso, and as we were struggling with that, a bunch of our folks left to go other places, and it's a zero-sum game at the end of the day. One of the good things that has come out of this is the DoD said, hey, maybe these cuts are not such a good idea. So now the 6,935 reduction in military medical end strength has been scaled back. Now they're only talking about a 2,000 instead of 6,900. So that's a big plus that has come out of the pandemic, at least for Army medicine.
Thank you, sir. I know that's an important thing. And for those of you who are civilians and have never been in the military, the DHA is a Defense Health Agency, which is a new stand-up organization. It's supposed to oversee all of military medicine from all the branches. Is that correct, Mike? Oshiki?
Yes, so the Defense Health Agency on 1 October 2019 assumed authority, direction, and control of all military medical facilities across the DoD, and there is a good piece to that in terms of standardization. You know, like, why would you have a different process of getting an appointment if you're at Fort Bliss than if you're at Fort Bragg, North Carolina, or Fort Lewis, Washington? Why is the system different in each of those places? Why is it why do we use 70 different IV pumps across the military health system? There's no reason for that. There's opportunity for some standardization. So there's a good piece to this, but what you don't want to throw out the baby with the bathwater, because there are unique things. The care on board a ship in the middle of the ocean is different from taking care of a fighter pilot, which is different from taking care of an infantry soldier in the middle of Iraq. So there are service-specific differences that we still have to take into account. The care we deliver in a hospital in El Paso, Fort Bliss, that is going to be very similar to the hospital care that you get wherever you are. But that's only one piece of the military health system. The operational piece is another one, and that's I think the DHA is very focused on the healthcare delivery in the fixed facilities, which is important, but that's not all there is. And the service-specific differences that are operationally relevant are very important, and that's where the DHA really doesn't have a role in delivering that operational medical care, and that's what makes military medicine unique. If it was just fixed facility healthcare, you wouldn't need a military health system to do that. The whole reason we exist is to do the things that the civilian healthcare system can't. Well, hopefully that makes sense.
Hey, Colonel Oshiki, this is Chris Lindner. Quick question for you. Where are you guys at with your coordination on training with the level 1, level 2 trauma centers in El Paso? And where do you see the maturation of that collaboration going in the future in El Paso?
Hey, Chris. Yeah, as you have seen firsthand, we are in El Paso. Our partnership is very robust, and it's a model, I think, for where we see a lot of things going in the DoD in terms of collaboration. Right now, for example, our surgeons are doing Chris Bell is one of the trauma surgeons from William Beaumont that is one of the trauma care providers for the city of El Paso, because he works in other facilities. Justin Orr, Dr. Orr, same thing for orthopedics. So we see our surgeons working in our civilian facilities as part of this partnership. The challenge is to take it to the next level. So it's great that our surgeons are able to do this, but we need to do it for the entire medical team as well. So the OR techs, the critical care nurses that care for someone after surgery, we need to get the whole team involved and take it beyond just the provider and expand it to get the entire military care team together. And so Jason Sipanik, the commander of the 528th Hospital Center, and I have talked about how we can do this, and partnering with our civilian partners. Dave Shimp at El Sol is looking at bringing an entire care team in so that our nurses and our OR techs can be a part of that experience as well. So there's tremendous opportunity there.
Anybody else have any questions they'd like to pose at this point?
Hey, this is Sarika. Colonel Oshiki, about a year ago, I read an article that mentioned that, what was it, DHA or maybe MHS had partnered with HCA for their graduate medical education. Has there been any progress or any updates on that partnership with HCA?
So, hey, Sarika. So the General Brian Line, actually had taken a position at HCA after he retired and was working on that. And then he got subsumed by the Borg. Now he's working for DHA. He left HCA, but that was a great initiative, I think, to look at these partnerships. And even though the General Line's not there anymore, I think we see the graduate medical education opportunities. We are sending our residents to HCA facilities in UMC and other areas in El Paso to do rotations where they can get a more robust experience than we can offer at William Beaumont. Conversely, we have Texas Tech residents in our facility doing stuff. So I think we will see more and more of these collaborative efforts on graduate medical education going forward, because that one of the things that we know about El Paso is it is as a medically underserved area, there are opportunities. I mean, there's more need than we have ability to deliver care for now. So as we look at graduate medical education, as we look at training for the nurses and medics, there are so many opportunities in our community to expand beyond what we're doing now.
Thank you, sir. So looking at the clock here, we have about 10 minutes left. And of course, if your schedules allow and the audience wants to continue beyond the hour, that's fine as well. But I want to make sure that before we get off this call, that we at least have a brief conversation about the future of the new Beaumont Army Medical Center, opening date, challenges, opportunities. I know that's a front of mind question for all of us.
Sure. So as of today, we are still on track to move the inpatients on the 27th of September and first patient care day for outpatients in the new hospital on the 30th of September. It's challenging. COVID has slowed down the supply chain. It has impacted the workforce that's working on the new hospital. If we have to shift, it's not going to be by much. I think you'll see that hospital's going to open this year. If we miss our mark for the end of September, maybe it'll be October. But it's not gonna move by much. So that's going to happen. The bigger question, I think, that Mike Amaral and I are really struggling with is the phenomenal partnership that we have in our current facility. When we move 10 miles down the road, that's challenging for the VA. And Mike is working very hard with Congresswoman Escobar's office and others to fast track that they've got real estate on the new campus, but they don't have the funding for a new facility. Mike, do you want to talk about that?
Oops. Yeah, I was going to hit on that. There's been no strategic planning in the El Paso VA for forever. And that's why we're behind in what we need for space to provide the care we need for our veterans. Our predominance, our core functions are primary care and mental health. I have about 8,000 veterans that I send out to the community for primary care because I don't have the capacity to see them in my system. We're fixing that. We're opening the new West Side CBOC here in the next couple of months. We were a pilot project for the entire country on what they call an as-built lease, which allowed us in 6 months to get a lease on existing space that was already configured to provide primary care. And so we're going to be able to add more teams up there in the next couple of months. But the bigger piece, like what Mike talked about, is I don't want to be an island unto myself on this campus. There were some balls dropped years ago that led to us being in this situation. But right now, I'm working with VA Central Office to find out, because Mike Brennan, who was the project manager for the new William Beaumont when I first got here back in 2011, is now the guy in charge of all facilities for VA up at Central Office. And so we're having a discussion about the process and, you know, projects that are ahead of us, are they really a higher priority when it comes to the mission and providing care for our veterans? And there's a lot of traction right now that if I can get the sizing of my facility appropriate, that we may be able to get this thing fast-tracked. Fast-track means instead of what is normally 8 to 10 years, that it could potentially be 3 to 4 years. So, you know, we're pushing that. I'm working with Mike because a lot of it depends on the services that I can get from William Beaumont. There were some things, you know, when I said shoot for the moon several months ago, we added inpatient substance abuse. There are a lot of services that we both need, neither of us have, that we send it all out to the community. Now, I'm not looking to build the capacity to bring everything from the community. That's never going to happen. But, you know, things like inpatient substance abuse, inpatient rehab, Mike's team does great job with all those joints that they replace. Some of them require inpatient rehab. We send it all out to the community to be done. Well, why don't we build a capability so that we can bring some of that in-house, recoup those federal dollars, and provide some of that care. So right now, those can be done as separate projects. They can be a separate building. What I'm trying to do now is get a building that's going to be somewhere between 500 and 600,000 square feet. That's on the William Beaumont campus. Because that's the square footage that I'm told would be doable, that we could actually build it in 3 years. So, you know, we're working all that stuff now. We're going through our numbers because I also don't want to build something that I know is going to be too small for our current demand. That's not going to happen. And with our growth of veteran population in this market, I need something bigger. We have challenges in this building all the time just because it was not a well-built building. And so the maintenance costs that we're going to have on top of things that we will have to put in place to be freestanding long-term, it's a waste of our tax dollars. So that's where I need, and I've got support. I've got a lot of support in DC right now to get this project moved forward. So really, that's it. Again, ideally, 10 years ago, we would have been planning a joint facility. But you know, we missed that opportunity. But I think that we can do some of that with some of these other functions that I was just talking about when it comes to expanded functions of things that neither Colonel Oshiki nor I have, but both of our populations require.
Thanks, Mike. Appreciate it. Looking at the clock, we're running out of time, so I would give the audience an opportunity to ask one last question before we ask each of the mics to give us their closing comments. Does anybody have any questions they'd like to pose?
This is Emma Schwartz. How can we help you as a private sector community be more effective in your plans moving forward?
Emma, I think you guys have been, all of our partners in the community have been absolutely phenomenal. We are working right now on a lot of these opportunities. The transition of military medical folks as they leave service, that's a huge opportunity, and that's something that, you know, Chris has been working on, and I think that we are making progress on helping these soldiers that are transitioning to become a part of the El Paso community when they leave service, and they go from wearing a uniform to being the members of the civilian healthcare community here in El Paso, and keeping those folks here. I think that's a tremendous opportunity that it's a win-win for the transitioning soldier and for the community if we can keep those folks here. Another opportunity, I think, is what we were talking about before in terms of collective training for our military medical teams. So if we can get a forward surgical team working together in a civilian facility to do things that they're can do at the opportunity for us as well. Mike Emerald, anything to add?
No, the same thing as what you said, Mike. I mean, I've said this in multiple forums. The support that we get from the community for both the DoD and the VA population is like nothing else that I've experienced anywhere. It's part of why I decided to stay in El Paso and make it my home. You know, and I saw Ben Miranda join. You know, for us to stand up the 101st Community Veterans Engagement Board and the amount of engagement that organization, I see some of the other names on here who have been part of that. That's why there's no doubt in my mind that if there's some place that a true joint endeavor between DoD and VA would work, because we know we have the safety net of the community out there to pick up those other parts that we will never be able to take care of, that we'll never be able to provide in-house. So, you know, there's, in terms of my piece of it, mine has all got to do with, you know, now, if you have about $800 million, that would be very helpful to me for my project. But, you know, short of that, just, you know, you guys, anytime you're talking with the Congresswoman, talking about how great this relationship is between DoD, VA, and the community, and, you know, that's really the thing that I would ask.
Well, thank you both. By the way, this has become the new Mike and Mike show. For those of you who follow sports, you'll get my joke, but this has been much more valuable than the other Mike and Mike show. Any closing comments from either one of you gentlemen?
Just to echo what Mike Amaral said, we are the beneficiaries of the tremendous support in the community. From a lobbying perspective, getting a common pharmacy benefit getting rid of the co-pays for the mail order pharmacy, that would be a huge win for both populations if we could be on a level playing field. We appreciate that support, and I think on behalf of both of us, we just want to say thanks for all you guys do to support us.
Yeah, totally agree. Couldn't say it better. Thanks, Mike.
We'll be all over it, gents.
Well, thank you all again. I want to thank our audience for joining us today, taking time out of your busy days. We greatly appreciate it. Colonel Oshiki, Mike Amaral, you guys did a great job. I certainly learned a lot this morning, and I hope it was as mutually beneficial to the rest of our audience. So with that, I think we'll bring it to a close. Have a great Monday. Have a great week, everyone. And thank you again for participating.